So today, my job as moderator is to talk to you a little bit about something that you haven't heard too much of, which I think might be a paradigm shift in treating these anatomic total shoulder arthroplasty problems that you see, and getting rid of them, where we're going to treat it with a non-spherical humeral head and an inlay glenoid. And the reason for this combo is that the humeral head shape reduces the stresses on the glenoid side. It has been applied, and there are outcome studies showing that even in these severe glenoid deformities, it works, and it reduces the stresses on the glenoid side, especially with an inlay component, by at least 10 times. So I think we'll go, without further ado, to Dr. John Zvijac, who's the sacrificial surgeon today. He's in Miami, my new and current partner, and my old partner from the Cleveland Clinic, Dr. Sal Frangimore, who has developed significant interest and now has converted to his total shoulder arthroplasty practice with this. So John, I don't know if you can hear me, but you're on screen. So
hey, Tony.
Hey, how you doing, man?
Doing great. You guys came in at a perfect time. Welcome to Miami, technically Coral Gables, Florida.
Can we see the palm trees?
Oh, it's beautiful out here today. It's about 102 and 97% humidity. Perfect day.
Awesome. So we're a little late, so maybe you can just fill us in terms of what the patient.
Well, this is one of the ones we've been doing today. You guys actually came in at a perfect time. So this is his X-ray, a 65-year-old gentleman. Can you guys see his X-ray up there? He's got severe DJD on a glenohumeral, both sides. A lot of huge osteophytes. I already chopped that one off for you. I know, Tony, you don't like to take those, but I usually do that. So it helps me pick my size better, even though I've done a little preoperative planning. You know, we got rid of the loose pieces and such. So we're actually right at the point of putting a, I'm going to use the claw first.
Hey, John, what type of glenoid is it? We didn't see an axillary view there.
So it's probably a B1. Okay. It's got a slope, but it doesn't have a secondary groove. It's a little bit of posterior luxation. We'll try to put that X-ray up for you.
Okay, perfect. So tell us what you're doing then.
So I'm going to use, today I'm going to use the ovo motion as opposed to the straight ovo. Kind of a tight guy, as you can imagine, had to do a little bit of release to get his head out. But it came out relatively easy. So I was just going to show, I don't usually use this thing. Some people do. This is a claw. I don't know if you guys can see it.
Yeah, put it a little close. Yeah, there you go.
Yeah, and it goes in like this, and people use this to size and to use for putting their pin. I'm old school, so what I do is, for a couple of reasons, I use the reamers, and I size them up. This one happens to be a 50, so that means it'll be a 50-54 head. That's what I had sized. I was just playing with these while I was waiting for you guys. And it seems like a 50-54 is the right height size. As you well know, it's longer A to P than medial to lateral. So that's what we're dealing with here.
So John, this is Sal. When you're in between sizes, when you're doing that, do you lean towards going a little bit smaller? And what are you really looking at, the superior to inferior or medial to lateral when you're getting your measurement?
So the main thing is I always lean smaller. I've learned that lesson early on, that you go one size down as opposed to one size up. And one of the beauties of this is, as we all know, inclination, version, angle are all different in different people, and even in the same person in different shoulders. So I put many a different size in one size than the other. So this is basically makes it allowable to use their head as the guide to reconstitute the new humeral head. This one's got a little bit of eburnation. We'll talk in a minute. We're going to leave it a little bit proud, but it allows me to look. I can feel the neck. I can see the size. I can look at my version, my neck version, and there's a little bit of osteophyte down there that I'm trying to take off here too. So go ahead, let's put that pin in. I'm going to put the pin in and keep the thing moving here.
Yep.
Yeah, that's. I actually like to use that claw guide because I could take that superior part of the claw and kind of mallet it in right to that a couple millimeters away from the supra, and that's a nice way to do that also. But this is I haven't seen it done this way, so that's interesting that you.
So the
you
beauty of
measure
this
it
is
like
it
that.
allows me to look at, if I'm not happy with the version, the inclination, I can change it, and I can see through it. That's why I like it. So I like the angle, I like the inclination, I like the version. I think we're in great shape. Go ahead and. So now we're going to put the screw in next. Just give this a little bit of a push this way.
So this is a central core reamer, which you're
Yeah, we're going to leave
take
this a little bit proud.
So you saw some head
Yeah, right-
collapse, so you want to
right
leave
there.
it a millimeter or so
Yeah,
proud?
Chop here.
Yeah.
I'm going to leave that up just a hair. He's got a little, you can see on these x-rays, and you don't need an x-ray. We're staring right at it. I mean, it's definitely flat.
So I usually don't leave it proud. I'd rather err on the side of understuffing than overstuffing this joint, so that if you do this, don't leave it 4 or 5 millimeters proud. Just
No,
a millimeter
agreed.
or 2 here. is
Agreed.
fine.
Yeah, I usually leave it up just when they're this flat, I usually bring it up a hair.
Yeah.
All right,
Fair
so let me have a lap. Here, let's just reposition these retractors so we don't have any issues. There we go. There we go. All right, go for it. First thing we're going to do is ream off the osteophytes, and so this is our 50 reamer. There you go.
So
You're
as he
good.
mentioned, he's already got
Go
his
for it.
height, version, and various valgus angulation all set by the face of the humeral head.
I'm going to need a thin curved osteotome next. And this has got a stop on it, so got a little more to go. Obviously, these 65-year-old active but sclerotic shoulders, they got hard-ass bone.
You can't say ass on the
I'm sorry. I forgot you're in Boston. It's arse, right?
Rs, yeah.
Yeah.
Hard. Rs.
Yeah. Good. All right. Yeah, so we're down. All right, let me just have the curved osteotome and a rongeur. So we just get rid of these osteophytes here. Somebody grab a rongeur.
So
Oh,
while
just
you're
break
doing
these
that,
out.
at,
Yeah.
at this point, are
Let's pop those
you
out.
in terms of anatomic shoulder replacements? What is the kind of are you doing this for everybody, or is there a certain patient that you will not do this type of replacement for?
So I've been using this for about 11 years, and my indications have definitely gone to this is my primary shoulder for most people. Obviously, if there's issues that, cuff issues that require reverse or, significant, people are, I'm sure Tony probably has more to tell you about the glenoids, but, if they're B2s, I have no problems, but I think there's a big bony defect then. But I got to tell you, I'm pushing 500 of these now, and yeah, there's the cyst right there. He's got a little cyst on his X-ray too, but it's back there.
Are you
So
fixing?
I tend to use this. This is it went from athletes to young people to even 70 and 80-year-old people. Let me have the rongeur a second.
And are you fixing rotator cuffs with these, or is a rotator cuff tear a contraindication for you?
So we've put a few heads on top, almost like a CT8 type.
You're talking about for a massive tear.
Massive tear, yeah.
Yeah. No, he's
Oh,
talking
are
about,
you saying?
he's talking about
you-
with that small tear that's reparable. What do you do?
oh, for sure. Yeah, no, that's yeah, for sure. I've done that many times.
Yeah.
Yeah, I know.
Yeah.
I know you have, Tony.
I have done that many times.
Yeah,
with
yeah.
Really good results.
Yeah, I think it's an easier way to do it, in all honesty, than if you're using, the stemmed or even the short stemmed prosthesis. You just don't take so much bone. I do a lot of straight ovos. Today we're going to do the ovo motion, so this is taking a little bit more bone, but let me just have
And this doesn't compromise the fixation at all, because you'll see it still leaves a big rim on the periphery,
Yeah,
so
go
that actually Ilya Voloshin of the
gonna be
University
stopped.
of Rochester did a
Yep.
study showing that
yeah, let's keep going.
this
Oh,
amount of
Keep going.
peripheral fixation, when you compare it to other
Keep going.
stemless implants as well as stemmed
Keep going.
and short stemmed implants, actually is very similar to stemmed and short stemmed implants. So that periphery of bone that you're going to see that he leaves behind here actually gives you significant fixation, which
little bit
makes
farther.
it comparable to a stem type implant.
There you go. Now you're done. Okay, perfect.
So this was done
So-
to help people with exposure of the glenoid.
Take the,
because sometimes
yeah.
these tight shoulders.
Take that out.
So
Just take
John,
We have a
You've
curve
got now
turret.
some, you're going to take that, the central portion out, you take it out.
Yeah, usually when you screw it out, sometimes, there's this little extra piece of bone here. I don't know if you can see it
Yeah.
right here with this technique, the oval motion technique, but often it just comes out right with the screw. If
Yeah.
not, I just take an osteotome and finish it.
Yeah, perfect.
All right, let's just take this out, take the pin out. Somebody pull
So-
that pin out for me.
What if this bone is not as hard as you anticipate it's going to be? Like typically those reamers
Irrigation?
have a hard time getting it through, but what have you ever
Kidney basin?
have you used that extra bone to kind of fill in the that central hole to give your screw some more purchase or anything?
Yeah,
Give
I've
any
done
tips?
that. I've used tacto set at times. I've used cement depending on the size of the hole. I was a little concerned looking at this guy because he did have some cysts, but when I did my measurements beforehand, I was pretty sure I was going to miss it, which I did. But all right, let's going to go to the glenoid. So we're going to take this out.
Perfect.
This out.
Now, you've done all your soft tissue releases, I assume?
Yeah, that's how when I was waiting for you guys, that's what I was doing.
Yeah, it's our fault, I know.
Yeah. Let me have the posterior retractor.
So do you do a biceps tenodesis with these patients?
My fellows do.
And then,
I think we're the only people down here, Tony, that we John and I still save the biceps, but
I know.
I think we're a lone breed. I mean,
Yeah,
people,
you are. I used
almost
to,
everybody takes them. Yeah.
if it was normal, but then Ionati taught me a lesson because I had a patient who had a
gotta
perfect
move this
result
light down.
except he had anterior shoulder pain. So I sent him to Ionati for a second opinion, and then Ionati saw me in the hall. He goes, "Why don't you
Really
just cut
cranking
the frickin' biceps every time?" And I go, "Why? It was normal." He goes, "Because then they wouldn't have to come to me for a second opinion."
Yeah. So I've had to go back on a couple scope. Let me have Obligate here.
So
I've had to go back on a
take it
couple of them
workout.
and cut the biceps. I have
Yeah.
done that.
Yeah.
But
So-
I guess I get it. I'm still a sports medicine doctor, so
Yeah.
I'm not officially a shoulder doctor like you guys. So let me have a Bovie.
It looks like you're in a shoulder, so it,
Yeah.
Yeah, I'm not either. When I
electrical.
decided to do a sports fellowship, Dr. Ionati told me that I was not a shoulder surgeon either. So here you go.
Just suck in there. Yeah.
So do you do a complete capsulectomy? Do you ever save the labrum? What are your indications for?
There are times that I used to not do any of that, Tony, but now I do all of that. I often save the labrum. This guy was pretty tight, so I'm going to free this thing up. His motion when he was asleep wasn't great. I don't know if you guys, can you see the glenoid in there? Can you guys get in there and see that?
The angle's just a bit, there you go, perfect.
Perfect. Let me
we're
just
looking
get
at
something to point with.
Very
Don't
sclerotic
free.
glenoid.
Yeah, so he's got a very sclerotic glenoid. He's got a little osteophyte up here. Those sometimes I leave you, but if you have to at least pay attention to when you're putting your glenoid in. And so here's the bottom of the glenoid right here.
Yep.
Back. I think we got a pretty decent look at this. I'm going to probably put this right about there. Once you
So I
irrigate
think
it a
this
little
is a
bit.
good example of why this system is very nice,
gonna look
because
back
a
here.
lot of the patients that you see are these really muscular, tight shoulders, and having this
We have the pin for this.
off-centered guide that you could use really makes it easier to you don't have to externally rotate and pull that femoral head down so much. Makes this part of it, the part that you worry about the most, part you don't have to
Yeah.
worry about as much.
We have a,
The other little trick sometimes, if
All
you're
right, I'm
having
sneaking by.
trouble, is to put, I
by,
usually
come
put
by.
like a small a curved Dara retractor
All right.
down in that
can you pick
posterior
the head up
anterior
or
quadrant,
pick the arm up a little bit?
just to
All right.
push down the head a little bit.
So I don't know if you guys can see
good.
this, but
So-
I'm kind of sizing this glenoid. I think this is most of the time I just put singles in. Can
Yeah.
you suck in there a little bit?
So I know you guys
Um,
do that. John, do you really care where the position of this is? When I first designed this, it was meant to be in that inferior circle of the glenoid, but
Yeah.
the data doesn't show that it makes any difference. So do you care where it goes other than sort of somewhere in the middle of the
Well,
glenoid?
I don't know if I see a lot of differences because I see a lot of them around, but I still want to, if there's like a B2 glenoid, I still want to take care of that. I
Yeah.
still want to, Make sure you want to make sure you have bone around there. That's important.
Yep.
So what do you do in that case if you do have a B2?
Do you just wait for reaming, or do you take it down? Do you take the ridge down?
If it's a true rim, I'll take it down. I'll take a little burr and burr it down.
Yeah.
But most of the time, I just ream over the top of it.
So I don't always take it down. I used to do the same, but then I just let the reamer do it. The key is that because there is a little bit of a shelf there, you have to make sure that the posterior edge of that guide sits on the posterior part of the glenoid, so that because you don't want any of the implant to be sitting proud. Sorry, we're chatting. It's like having a chat at dinner time.
So this has, the double lines for the snowman and a single line for the single one, and I think a single one's going to be very nice here. I guess you guys can talk when I'm reaming this stuff. You guys can talk about, one of the things we always talk about is centering of the head, right? I'm sure I was listening to some lectures while I was working, and you guys were talking. 15, yeah.
Yeah, well, Gus won't let me talk now. He says I'm distracting you.
Oh, and one of the things is that well, I always used to believe that it was the glenoid, right? That it was in terms of centering of the head. But one of my partners who doesn't put the glenoids in, and I used to tease him, it's because he couldn't get to the glenoid. But the reality of it is he puts these heads in, and it centers. And it centers. Yeah, so maybe there's something about the aspherical humeral side that I'm not bright enough to catch on to. Ready? Perfect.
So this also has a stop on it, but what he's doing is it's at an angle. It's hard to appreciate the angle, but he's coming in at an angle so that it reams it eccentrically, but you end up with a spherical base to it, and you'll see that the implant has a spherical base.
Yeah, so there is a stop. I use it, but more importantly, I usually use the four rings in the back. And I usually I actually open up a 15 and then go to a 20. That's what I usually do. So
that they make twice as much money?
Yeah, I feel bad for these guys. Let me just have a Rondura grasp or something.
So what was the biggest difference when you started using this type of implant versus a traditional anatomic shoulder with an onlay? Did you see anything different with range of motion, or what kind of drew you to using this more consistently?
So several things. One is the range of motion I found better. Two is they didn't get that, sometimes people get that humeral pain from knocking down the stem. I'm just sizing this up here. Ooh, that looks, maybe another micron, huh? Let me just have the 20 back one more time.
So he's just going to ream a little more again because it looks
most importantly, two things. We actually just got our 10-year data coming out, and we have 17% of people have had their other shoulder done in the same year, which is unheard of. The statistics say about 6% of people do that. I just want to get another millimeter of this. I like that. That looks good. So that was, people, as soon as they got the one, they got the other pretty quick, and they rehab much quicker. Obviously, I can't tell you the last time somebody ever stayed in a hospital for this.
Yeah. So you do these all as outpatients?
All outpatient. Yeah, we're in a surgery center right now doing this. All right. I'm going to take this pin out.
Yeah, I think sometimes initially, get the range of motion. I think that it's, especially in those very active individuals, they could get that range of motion a little bit quicker. I think without lateralizing the joint. Really, the idea of overstuffing is almost taken away from, at least from a joint medialization or lateralization standpoint. I'm sorry. And I also think that because we're doing these in younger people, that if they do happen to have a rotator cuff that fails in the future, you get rid of that rocking horse phenomenon, and it's almost like having a Hemi, which is what we used to do before reverses got really good. So I think that,
the other thing is, let me have the other thing that you mentioned is is, you have the mallet. The glenoid loss, you know, we've been, obviously that's, you know, I've given a lot of talks on this, and people are keen to mention this whole inlay, which I think is a brilliant idea, but, you know, obviously people have their reservations about it. All I'm doing is making the centering hole a little bit more.
Yeah. So John, I think we have about 15 minutes here, it looks like, on the clock.
We have the-
Justin's getting fidgety in his seat.
Okay.
He's starting to email the security.
Okay.
Escort me from the facility.
Zoom in. See where he put it in, so you can see the trial.
Concentrate.
All right, so we got the trial glenoid in. I don't know if you can see that or not.
No, we can't.
Look at that.
Oh. Okay.
Get back over here on the shot.
There you go.
And would you suck in there a little bit? So you can see, you got a dental freer.
Give us the
Yes,
other
sir.
angle again. The other glenoid angle.
There you go.
Over
Hold on
one
a minute.
shoulder, I guess.
There you go.
Yeah, there you go.
Yeah, so you can see we're spot on in terms of the joint. This is so we got a nice coverage. We've got definitely, it's a load sharing device. The reason we had them put the string on here is because so many times we got it in there, I couldn't get it out. So we got the string so I can pop it back out.
And then do you drill holes for your cement?
Yeah, I usually just take somebody want to start mixing cement? Troy, why don't you start mixing cement real quick?
Yeah, I reminded him.
Okay.
Put the
Yeah.
cement.
Yeah, what I usually do is use the awl. I just punk holes with the awl. Give me the awl back.
So while you're mixing that, Tony, and I could ask you, with this,
Mallet.
with maintaining so much of that bone on the humeral side, do you fix how you typically would in like an open subscap repair, or do you do anything different? I mean, that's another thing I really like about it, is I could fix it with a double row repair like I would if I was doing an open subscap repair.
Yeah, exactly.
seems to work out
yeah,
really well.
I tend to I don't take any bone. I take, cut the tendon, and that's exactly what I do.
Yeah.
Oh,
So
the other point I wanted to make was, in older people, I don't know about you guys, but we have a lot of people that fall down here. And it's when they get these prosthetic fractures, they tend to be able to be treated non-surgically. I mean, you can, they'll fracture, but you can let the proximal humerus fracture heal and have a good result. We got a whole bunch of those that we're getting ready to publish. As opposed to, having to wire them and all that other stuff you got to do.
So when you were talking about the inlay glenoid, you've had a lot of
Okay,
experience with
okay.
this. Tony has. How many times have you seen one of these pop out or dislodge or have any issues with that? Because initially, when I was starting to do these, one of my big concerns was how, with the little amount of cement that we're actually getting in there, how how this thing wouldn't pop out. Assuming that you're not putting it proud, because I know that's one of the risk factors for it. Have you seen any issues with this, or how many times does something like that happen?
So I have not seen any loosenings or displacements. I've seen a couple. I have seen a couple where I think two where the patient had some P. acnes and he got loose and we popped them out. But we haven't seen loosening. And in fact, we're doing a study. In fact, we're just sending it out right now, where we've been paying close attention to that. So we've been doing. We've put in different quadrants and putting some cement mantle measurements. We've in there, and we take serial X-rays over time and CT scans, and so we haven't seen any cement changes over time. So there hasn't been any lucency over time. What it is when it starts. All right, somebody give me the pusher. Somebody got the pusher? Pusher. And a dental freer. Dental freer and the pusher, yep. All right. Mallet. Couple little tabs here.
So I guess Tony, while they're busy getting this in, have you had to revise any of these to reverses? And if you have, is that a difficult issue? Because that's always a concern with any anatomic
Yeah.
shoulders, how they could be
So,
converted.
so, you know, their series plus a few other independent series, including Nicholson out of Rush and our series. In each of those, there's been no reported loosenings. In my own personal experience, I've had 3 cases, all for P. acne, that we had to revise. We had to revise 2 of them. One of them, actually, after a scope and a washout, he became asymptomatic and didn't want anything further done. The other 2, one was loose, and the other one, the glenoid, was solid. And the one that was loose, and we treated with antibiotics and spacers and all that kind of stuff, the revision to a reverse is fairly simple, and that's what she has in place at this point. So there's a lot of different ways of doing the cement. I'm kind of anal about it. I have this little silicone finger so that I can touch the cement, which I start putting in when it's very liquid. If you've seen it, you know, when we were going through this trying to design something which would pressurize the cement, the engineers finally got pissed off at me saying, "What's the best thing that you've seen?" And I go, "My finger." And they said, "Well, what's the problem?" I go, "Well, when I put my finger in there and the cement is too liquid, it sticks to your glove." And they go, "Well, what if we gave you like a piece of silicone which doesn't stick to it?" So actually there's a little silicone finger. So the nurses are always saying, "When do we want us to give you the finger?" So that so I use a little finger, and I pressurize this about 5 times. He's using the cement a little more solid and pressurizing it with the stick, so you can do whatever you want. But I like to do it, and it gives you a nice cloud behind the implant when you're done.
Yeah, he's talking. Yeah, yeah.
So any questions from the audience? John, I'm just going to open it up, see if everybody's drinking heavily, and
Yeah, I'm just.
I don't hear any snoring, so that's a
I'm
good.
just hanging out till the cement dries. Now we can tell jokes or whatever. Just, you know, normally
Okay,
what goes on for the next 6
Does
minutes,
Mazaka
right?
have a question so we don't discourage or take concentration off the session? No? Everybody understand? Yeah, Larry. Yeah, so usually when you pop it out, some of the cement comes with it, but usually with it's interdigitated. I just try and create as much of it as I can out of there. It usually defines itself. If it's all loose and grimy, I just take all of that stuff out of there with it. But if it's solid, I don't go making holes, but I try and get as much of it out as possible. Oh, there you go.
I'm trying to get it turned on. Testing. Oh, it's on.
There you go.
Any questions?
Dr.
Sarah, any questions? Rob? Come on, think of a question. Oh, Javier.
Javier, there you go.
There you go.
A taker.
So let's talk about the aspherical head because
Yeah.
you know, you've noticed that patients have less pain. They seem to get their flexibility back. Why do you think that is? Just because it's more anatomic, or what is it about it
Yeah.
that centers the head? And
So there's actually, you know, everybody says, "Oh, I've never heard of this," but if you actually go through our literature, there's a lot of proof that our humeral heads are not aspherical. I think we all know when we dislocate the humeral head, it's not spherical. So that I think the anatomy has it, and Joe Ionati has the best actually paper out there looking at this, where he compared a spherical to a non-spherical head and showed that there was better range of motion, there was better stability, and the center of rotation actually moves like a normal humeral head. Whereas when we have a sphere, you know, just imagine the sphere is like a soccer ball, and the non-spherical head is like a football. So if you roll a soccer ball across the floor, that center of rotation stays in the same spot. In the football, it moves like this, and that's what our shoulders do, is that center of rotation moves back and forth, especially as we go through forward elevation, extension, and rotation. So you get that obligate translation that Mattson talked about. And I think that when we have a spherical head, in order for us to try and get range of motion, it has to almost force its way to move that center of rotation. I think that that's some of the differences of it. So I think that the mechanics is all much better, and then that reduces the stresses on it. So, you know, this is a little bit of heresy, but I think that, you know, the study would wait to be done. But I think that even if you just did a hemi in this case, without doing the glenoid, I think that they would do a lot better. And with if Mattson wants to do his ream and run technique, I think this would be the better head to choose than the spherical one.
Yeah, I agree with you, Tony. That's one of the things, you know, we've talked about that a lot, right? That, you know, Mattson did those great studies, but maybe he had the wrong prosthesis. Great idea, wrong side of the right side, but the wrong prosthesis. But that definitely, their motion gets dramatically better.
How are we doing on the cement? Oh,
But we're
so
almost
they're-
we're almost ready to pop the head. Yep, we're ready to go. We're going to pop the
Ready
head.
to put the head back
out.
on?
Yep,
Yeah.
yep, we're gonna take it out right
Because we
now.
got 5 minutes left. I'm just giving the 5-minute
Yeah,
warning here.
here you go. We're going to
I
put
don't,
the
want
head.
any,
That's-
I don't want any flags from Mazaka here.
I
No.
think it's also that total volume that you have in the
Get it.
joint is more similar to their native. I think it's less tension on the rotator cuff, and I think some
Let
of
me
that
have
early
the,
motion and decreased pain
Homans.
has to do with that also.
Get ready to put the head in.
Dr. Wyatter has a question from
Yeah, I got a
Detroit.
question. It's a great video. So that glenoid, to me, looked like a huge expansile osteoarthritic glenoid.
Yep.
And that implant looked like it resurfaced only about 25% of it.
Yes.
In my hands, I'd be putting the biggest extra large glenoid in my
Correct.
set in there. So
Correct.
you guys
So
talk
that-
about sizing and whether there's concern
So-
about metal on bone.
For many years, I've been, I can't say bitching, we can't say ass, but I have not been happy. No,
One more.
but we can cut that out. So,
edit that.
but when you look at the data, these guys have 10-year data, and they've only used the circle one for every patient. And when you look at my data where I've
Yeah.
used, so in the big
changes for that.
weightlifters, I put the biggest implant I can in there. But when you compare the data of the ones that I use, the big one,
Irrigation?
the small one, there is no difference in the data, which is very
switches,
interesting. So now I can't argue with the data, so I just do the circle most of the time. But I still, in some of those big guys where that glenoid's huge, I still put the double one in just because it makes it look nicer on the pictures.
Yeah, I agree. You know, the bottom line is it seems that usually the problem's in the bottom, right? But I think the biggest thing is the fact that it's, no matter what it is, it's not going to loosen. I mean, that's really the
Yeah.
key to me.
Yeah, we know that now as well. So he's got the humeral head dislocated again. You're putting the central guide pin down so you can now
Yep.
get
So
your
these are
central post.
Our
So this central post has
5450,
Yep.
5450, and we're going to put this down. And the nice thing about this oval motion is, Tony will tell you, I do a lot more ovals than oval motions, but the nice thing about this is that it fits flat. You know you got a great fit here.
Like I
And
said,
now we're just
the
stabilizing. Yep.
biomechanics of this, the fixation is actually fairly solid, and most of it is on the periphery as opposed to in that screw post. So that peripheral cortical surface there is really important in this operation.
Tony, when you're looking at this, you always you talk a lot about the times like this stays more centered
Yeah,
than subluxing back.
yeah.
Can you sort of talk about whether or not you think that's coming from the humerus or the fact that you're not changing the joint line more laterally?
Yeah, so, I wish I knew the answer. I think you asked that question because you know I don't know the answer. So,
No, you take this out.
I think that there's all these things contribute to it, the soft
Go in
tissue
and out.
releases, the shape of the
Take it out,
humeral
yeah.
head. But, Matson, in his Riemann runs, they recenter. So that there's something about not doing something to the glenoid, leaving it in its version. Because I think that most of the time what we do, and I thought about this a lot,
Is it not
that,
fitting
we
over
get
this
that
pin?
axillary view.
It's not fitting over this
It's a
pin.
static picture. We don't see what's happening
Take
dynamically.
this. We
These
have the
things
mallet.
may be sort of like
Mallet and plier.
rolling in and out, and we just don't know it. And then with
It's
an
not fitting-
on-leg
it's not
glenoid,
fitting over this
the
pin.
problem is that's a fixed device and it's semi-constrained.
let's go.
So that as you rotate, if you have any instability,
it's
it
the wrong
pops
pin.
off
Just
the
take it
back,
out.
which
Just take
won't
it out.
happen with this. This one just slides back and forth where it's been used to doing that for a while. So I don't know the answer to that question, but there's no
Okay.
question that they recenter and they stay there.
Just
We
take the drill.
published that in JSES a few years ago. All right. Did we lose picture? No.
Does it
Okay.
fit? Okay, let's
You
go.
ready? You got a couple minutes here to put that head on so everybody is really
Yeah,
impressed.
we're mucking
very
around here. They gave me the wrong pin. It didn't
So
fit,
yeah,
but it's
with
okay.
a minute 30,
Yeah.
can you
ahead.
go into what you use for your
Yeah, take it up.
subscap
take
fixation?
it up.
What angle you have the arm at, and do you fix it an external or do you fix it neutral?
I fix it usually at 30-30 or 60-60. Yeah, usually these people, it's usually not an issue. I mean, once they get the, yeah, just put it right in there.
Yeah, that's what that's what I've seen when I could fix it like I would do an open subscap, and
Exactly, yeah.
those are the rotator cuffs we
All right,
usually
screw-
don't have to worry about when they're when
So he's putting the screw post in. You can see there's a little shoulder on the screwdriver at the top, which tells you the distance you need to put the post in, because that's all measured to the heights of bone. So you don't want to over tighten this, because as you over
you go.
tighten
Good.
it,
Pop
you
it
put
up.
the screw post in too far,
You have
and
to
you
top
reduce
it.
the amount of engagement
it.
in the screw post, which then could potentially disengage your implant. So just as an FYI. So he's got a screw post in there. Everything looks great. See,
Yeah, I'm
he's-
just putting the top pad in to make sure the screw, I'm happy with the screw setting.
Yep, yep.
All right, we're going to
Looks
pop
great.
off the trial and you can mark the head. All right. Give him some rotation. Little irrigation after this, and then we'll grab the head and don't drop it, please. We're doing good so far. Don't make it. There
Yeah.
you go. There you go, John.
Looks great.
Yeah, I'm very happy. Looks good. As you well know, having done these before, there sometimes can be a little bit hairy, but I've got. Yep. Give him the head. Got the. I got my top staff here. I got Dr. Vargas in the building. Troy
Beautiful.
Poshik is our fellow here. Top-notch anesthesia. We got our top team of nurse,
So do you
Katrina.
you have a way of putting the head on
And
so that
John.
you know that you've got it in the right direction?
Yep, so what I do, it's marked, and I should have showed it to you, but you put me under pressure for time. But on the
I know.
bottom of it, it's marked
That was Gus.
54. And I take a marker and mark it with a line. I don't know if you can see it or not. So I
Yeah.
know where it goes, and I just rotate it so it just posterior to the biceps, superior up. And we got ourselves, check it, make sure it's on there. It's a nice Morris fit. Take
Perfect.
these out. We're gonna trial it
Can you
real
just
quick.
reduce it before
Yep, so
we
we're gonna,
cut away?
Yep, that's what we're gonna do right now.
Attaboy.
So there we go. I don't know if you can see this, if you can back away, but gets excellent motion here. Gets 90 a rotation.
I think there's no subscat.
Yeah, that's true. But you got good rock,
Very
I'm gonna-
good.
good beat, easy to dance to. I'm giving it an 85.
There you go. Well, listen,
Yep.
these are so hard. Everybody in this audience who's ever done one knows it. And you were the sacrificial guy today, but you have done a tremendous job, John. Thank you
Thanks.
very much. We appreciate it.
Enjoy the rest of your day. I wish I was up there.
Have a great
good-
day.
Yeah, you guys have a great day.
Thanks.